I'm Sally Sattel. I'm a resident scholar at AEI. And our panel today is to talk about the roots of the opioid crisis and to begin to consider what kind of federal response there should be. I say begin because this is just the first of several events we're going to have in a series called Opioids in Society. But we're going to talk today, but in the larger series, I should say, we'll also talk about the diagnosis and maybe even more of the remedies for it. Right now, we're in the early phases of remedial action, and many of the efforts really haven't been evaluated yet. So I got interested in so-called deaths of despair, which was a term coined by Princeton economists Ann Case and Angus Deaton. Actually, this got a lot of attention in the past few weeks, but the basic point is that longevity of whites, and in particular whites with low education and low employment prospects, between the ages of 45 and 54, their longevity is falling off, which is unique in this country. Every other group, and also ethnic, and also whites who are better educated, their longevity is continuing to increase, and that is also true of all first world countries. So this is very noticeable. They actually started to detect this trend in the 90s, that again, whites between low-income, poorly educated whites between 45 and 54 are actually dying off early. And among the causes are overdose from opioids. So what I'm going to do before I introduce the panel is a real quick orientation to the problem, with just a little background. I'm sure most of you are familiar with it, but then I'll introduce the panelists. And in fact, the first, it's not in the order of, Chris will go first, and then Chris Caldwell, and then Nick Eberstadt. They'll pretty much be in the business of description, whereas then Harold, Professor Pollack, and Danny Seiden from the governor's office in Arizona will talk more about remedies. So let me just start here real quickly. Okay, so this is how many people, this is the last count, it's from 2015. In fact, there was an article in the New York Times this week that looked at, it didn't take a national view, but it did effectively by going state by state. And if you were to extend that out to 2016, undoubtedly that number of 33,091, which was the number of all opioid fatalities in 2015, would be even higher. About 17,500 people overdosed from opioid painkillers. Those are medications that you know as Percocet, Vicodin, OxyContin, hydrocodone, these kinds of things. That was about 17,500. Then you can see heroin and fentanyl around 2010. Heroin started to increase, and then fentanyl around 2012. And in the next slide, you can see that it's heroin, and in fact, it says fentanyls because that also refers to analog molecules such as carfentanil. Heroin and the fentanyls have actually now are responsible for more deaths than the opioid painkillers. Heroin about 13,000 and fentanyl about 9,500. Many of the deaths attributed to heroin probably are fentanyl, and the reason why those drugs are such a menace is because they're extremely potent. Fentanyl is about 50 times more potent than heroin, and carfentanil about 5,000 times. So again, they're highly deadly, even to people who've built up tolerance. Although you can build up so much tolerance that people can survive and continue to use fentanyl, which they, in many parts of the country, that's pretty much what they are using. And final slide, you can see that prescriptions have been starting to drop since about 2011. But if you recall the other slide, all opioid deaths are going up. And again, that refers mainly to the fatal overdoses driven by fentanyl. And communities are just reeling under this crisis. This is obviously a woman who's overdosed, and hopefully that Narcan, naloxone, will reverse it. When people overdose from fentanyl, it often takes many tries, and I read the other day that some people are they're not injected. You can see in this particular case, it's a nasal spray, up to, can be more than 5, 6, they even said 13 times. And that means that there was an enormous, the potency of what this person took and the amount was probably quite enormous. Also, in addition to individuals now often requiring multiple hits of Narcan, and it's quite expensive, that same individual it's not at all uncommon for that same individual to be revived at subsequent times. So clearly this is an enormous problem, costing, in terms of human suffering, that's vast, but also in terms of expense, it's estimated about $77 billion a year. Foster care systems are buckling under the weight of addicted parents who've either died or are too incapacitated to raise their kids. And I think it's in West Virginia now that they've run out of they had funeral burial benefits and they've exhausted those. Another vivid tidbit that's quite horrifying is that some places in Ohio now have portable morgues because the coroner's office are already full. So again, just to give you a flavor of what pressure this is putting on communities. And these are the kinds of communities, I mean, it is spread across the country, but these are the, ground zero of this problem. A place like Ohio, Hillbilly Elegy, and J.D. Vance writes about communities that, in his words, are hammering jobs and hope. Here we're not talking about addiction so much as a medical problem, but almost as a social symptom. Again, this spectacular article by one of our speakers, Chris Caldwell, is really a fine-grained, I don't know, what is it, 7,000 word article, but somehow you pack so much granular detail. It's really an anthropological assessment, and where he looks at what it's like to use these drugs, what it's like to be a community responding to it, and also you get into the culture of the addiction treatment and how our society is thinking about addiction, which has changed over the years and in ways that are good and maybe a little bit complicated. Then this recent article by Margaret Talbot in the New Yorker is also a great look that drives home the degree to which the problem is normalized in some places. She was pretty much stayed in West Virginia for this story. And finally, Arizona on Monday just joined 2 other states, their governors, in calling for a state of emergency due to the opioid crisis. So if you clearly knew it was a problem before, but now we've made sure everyone's aware of the desperate situation we're in. So we'll start with Chris Caldwell. He is a senior editor at the Weekly Standard and author, as I mentioned, of this widely cited American Carnage story. And he'll discuss the social and economic devastation he observed when he visited towns in the Northeast, and also speculate on the cultural underpinnings. But before he starts, I'm going to introduce everybody first. And he'll be followed by Nick Eberstadt, who's the Henry Wendt Chair of Political Economy here at AEI, and the author of another much discussed article, but it didn't have a pretty picture, Nick, so that's why it wasn't up there, called Our Miserable 21st Century. Actually, those 2 articles together just about gives you the enormous window into this problem. That was in Commentary in February, in which he characterized the opioid crisis as a new plague for a new century. And he will present a more quantitative version of Chris's paper. He will be followed by Professor Harold Pollack, who's the Helen Ross Professor at the School of Social Services Administration at the University of Chicago. It's published widely on the interface between poverty and public health. And he'll talk about some remedies at a federal level aimed at economically distressed areas. He also had an important recent article, without a nice picture, in the New England Journal of Medicine on fentanyl, on the scourge of fentanyl, which really has in a way changed the face of this problem from a public health standpoint. And finally, Danny Seiden, Deputy Chief of Staff for Arizona Governor Ducey. He has seen the devastation up close, and will discuss what his state is doing and how the federal government can help. It did not do justice to the enormous achievements of these folks, but they're all in their bios online. So now, Chris.
Well, thank you, Sally. I'm provoked by or struck by a lot of the things you said. You know, a colleague of mine at the Weekly Standard just went to a funeral for an old friend and old friend's wife, whom he had known but he had lost touch with, and he went out to Ohio, and she died rather suddenly. It was last weekend. He went out to this funeral, and he discovered that she died of a fentanyl overdose, and in fact they lived in the Ohio suburbs of Cincinnati, and the weekend she died, there were so many overdoses in that area that they had to send her to Kentucky to be autopsied. And so this is the sort of thing that's happening everywhere. We're basically talking about the equivalent of the old heroin problem, which Americans are somewhat familiar with, but it's kind of tentacular. It involves other things. It involves prescription pharmaceuticals. It involves lab-made analogs to opiates, which are known as opioids, and they include legal ones and illegal ones, as Sally said, and it's at a really large scale. Sally was showing you some slides of the deaths per 100,000. That's the way that the Centers for Disease Control tend to measure mortality in terms of per 100,000. And so to put that in perspective, okay, when we talked about the real rise in heroin at the beginning of the 1970s, when two things came together. One was a sort of a collapse of order in the inner cities, and the other was the return of a number of heroin-addicted soldiers from Vietnam, and that was the worst heroin had ever been since the 19th century. At that point, people were dying of heroin at the rate of 1.5. People are dying of drug overdoses at 1.5 per 100,000. In 1986, when crack came in, that struck people as an even more serious problem. People were dying then at the rate of 2 per 100,000. The statistics that Sally just showed you are above 10 per 100,000. According to the new numbers we have from the New York Times, which has tried to synthesize the state data from 2016 because it comes out quicker than the federal data, we're up to about 12 per 100,000. In the state of New Hampshire, we're at 30 per 100,000. In the state of West Virginia, we're at 40 per 100,000. It's a problem that is absolutely colossal in scope for the time being. And you know, we've called this deaths of despair. I think that a lot of people are struck by some of the rising mortality statistics among white people in the United States and in rural areas. I'm not sure how close the link is between drugs and that, although I'm not an expert in it. I was struck actually more in writing about this in New England by what an equal opportunity destroyer this drug crisis is. People have always said that, you know, heroin can take anybody. This is a problem that goes from jail to Yale. And that's true in theory, but it has not really been true in practice. But I think it is now. I went on a buying operation with a police department in a New England city that I won't name, but I was with a team of 4 or 5 narcotics cops working undercover, and one of them was a really twinkly, sparkly, Ivy League-looking 23-year-old girl. Everything, she just looked just like she had the whole world in front of her. And when we sat down and we discussed what we were going to do, they said, okay, now she's going to go and buy the drugs. And I couldn't believe it because this girl looked like she just got out of like some sort of like Princeton sorority party or something. But she was the person who was going to go into harm's way with armed men among armed men to buy drugs because she looked like a totally plausible candidate to be a drug buyer. And that would not have been the case 20 years ago. So I do think, but I do think there's actually quite a diversity among this problem. I mean, in Rhode Island, which is one of the states I visited, the population of Rhode Island is 85% white, 9% Hispanic, 5% black. The people you get in the Anchor Recovery Services, which is an addicts helping addicts thing, the people they find in emergency rooms are 82% white, 9% Hispanic, 6% black. It's almost a sort of a totally random thing. I don't think there's much social difference in who gets affected. I'd just like to say a couple of words about the history of this. You know, the United States has a big problem with substance abuse, so this is a long story. The specific problem with opioids, I think, has to do with the confluence of three things in the 19th century. In the start of the 19th century, scientists were able to isolate morphine, the chemical in opium poppies. In the 1850s, we invented the hypodermic needle. And in the 1860s, we fought the bloodiest war in the history of the planet. And a lot of people came home with what we would now call chronic pain, and the ability of the uses of this drug just seemed to be infinite. It was overprescribed. You know what happened, or you can predict what happened. A lot of, mothers and teachers and sort of like pillars of the community got addicted and died, and there was a lot of agitation. This was a major progressive achievement of the turn of the century to get the first narcotics laws passed just before World War I. And at that point, opioids became totally taboo. I mean, Americans just didn't use them. Doctors just didn't prescribe them. There was, with the exception of end-of-life care. But although they weren't being used, there were advances being made in synthesizing morphine into heroin on one side, but also into creating opioids in the lab. And in 1959, you had the invention of fentanyl. That was used in end-of-life patches. We'll get to that a little bit more later on. And in the 1990s, companies began to think it would be possible to deliver opioids in time-release pills that would be relatively safe. And the key episode in this is the release of OxyContin, which is time-release oxycodone, by Purdue Pharmaceuticals in 1996. And they designed the pill to be tamper-resistant so that it would be released over time. But it was only weakly tamper-resistant. Turned out you could chew it, you could smash it, you could boil it in water, you could add acids or citric acid into a great big dollop of opioid, and addicts tend to be very reformulated their OxyContin. But at the same time, there was a lot of.
Okay, there we go. So I'm going to talk about not just the deaths from opioid poisoning, but a bunch of other things that have attended the rise in deaths from drug poisonings, because the rise in opioid deaths isn't a onesie. It comes along with other tendencies as well, including increasing deaths from suicide, increasing deaths from cirrhosis, and as Sally mentioned, Ann Case and Angus Deaton described these as deaths of despair. That doesn't seem a totally unreasonable or arbitrary description. I'm going to look at what's happened with non-Hispanic whites in the US over the last decade or so, and I'm going to try to compare this to some other things that we know about, just to try to put this terrible situation in a little bit more perspective. Okay, so this is the kind of canonical Ann Case and Angus Deaton slide showing the changes in death rates for different groups in the US. And until Ann and Angus did some of their work, somehow the public health community practically had overlooked the fact that Latino mortality levels are way lower than the US national average, and in fact way lower than Anglo levels. That's kind of a neat thing to be able to overlook for a couple of decades, but it's possible, difficult but possible. The blue line there, the dark blue line, is Anglo mortality for people in their early 50s overall, and you can see it's going up slightly. But the horrible uptick in the red line is for Anglos in their early 50s who have high school education or less. And you can see the crossover between the Anglo and the Afro-American, African-American lines in about 2010. This is only for the 50-somethings, but they're basically the same tendencies for 40-somethings, 30-somethings, 20-somethings. And you can see those valleys of death that you can see there. I'd like you to pay attention to the coloration, just the kind of the image of 2014, because we're going to get back to that and compare it to some other things. This is for the Anglos. This is what's happened in the not so distant past. Okay, so this is non-Hispanic white life expectancy by state around the year 2010. And you all are very lucky to be in Washington, D.C. if you're Anglos, because Washington, once again, is exceptional. I guess I have a few guesses for why that might be. At the other end of the spectrum, we see like West Virginia, Alabama, Kentucky, so forth and so on and so on. What does it mean to have a life expectancy of under 76 for a population group in the US these days? The world is a moving target, and global life expectancy is now higher than 70, okay? And if we go through a list of countries that are low-income third world countries, we can start with Algeria, which is about 78, and then we can get to Argentina, which is over 80, and then we can get to Azerbaijan, which is about 76 or something. I mean, and this is just like going through the A's, right? But the point being that in a lot of the US today, overall Anglo life expectancy levels are comparable to third world countries or below that of third world countries, which you'll be familiar with. And just to make the point again, we've got the Anglos here, and I put the Latino life expectancy in various states next to that. So we've just superimposed, those blue spikes there are the Hispanic life expectancy in various states. Anglo life expectancy is substantially lower than Latino life expectancy in the US today. And this is an important, interesting, and almost totally neglected fact in public health research. Researchers take note. So here again, we're going back to Case and Deaton. This is their layout of just the deaths of despair, which is in their taxonomy, drugs, suicide, alcohol deaths. And you can see there are hot spots. There are very hot spots in different parts of the country. Do take a look at the shape of the map. Do take a look at this geography, because we're going to get back to it again also. How does this relate to some other things? Well, one gateway that we really need to pay attention to is the Medicaid program. This chart here addresses the whole question of government program dependency by the 7 million guys who are between the ages of 25 and 54 and are neither working nor looking for work. This is some homework I did for a book last year called Men Without Work. And it's broken down by educational attainment. Guys who are neither working nor looking for work and have a high school, less than a high school degree, have about 75% enrollment in at least one disability program. Why is that important? Because disability programs establish your eligibility for the government's low-income health program, Medicaid. Why is Medicaid important? Because following on what Chris was describing, after the revolution in thought and in technology about pain pills, you could go to a pain pill factory and get a pain pill script for 90 OxyContin for a month for $3 of your own up front, and Uncle Sam would pay for the rest through the Medicaid program. These rules are being tightened up in different places, as you saw from Sally's slide, but there was a horrible, deadly unintended consequence to this increasing dependence upon Medicaid. And just last year, Alan Kruger of Princeton University did a paper where he reported that about half of the guys in this pool that I'm talking about reported taking pain medication the previous day. So there's terrible unintended consequences here. We have seen things like this before. This is the age-standardized mortality level for African Americans from 1980 to 1998, and you'll see that the decline in mortality for Black America took a horrible holiday for about a decade and a half. Part of this is the crack epidemic. Part of this is the HIV epidemic. What we're seeing in the Anglos, and especially in the rural Anglos, is a sort of an echo of what happened in Black America within some of our lifetimes. It has happened here before. It's also happened in other places. Back in the right before German unification and right after German unification, I spent a bit of time in Eastern Germany doing some demographics homework. One of the things which happened in East Germany, despite a fire hose of less.
But overdose was just always there, and it's a very cruel thing. Because it so often strikes people who've experienced some loss of tolerance. And what that means is, very, very often it's people who have gone through some period of detoxification. Very often they're people who are trying very hard to stop using. They've entered a treatment program, they've gone to jail or the hospital, and they come out and they use the same amount of drugs that they used 2 weeks ago, and they die. And we see all the time a teenager from Chicago suburbs overdoses when he was just on the road to getting straight. And people often read that in a very cynical way, but that is very often the path. It's precisely the people who are trying to stop who are in some ways experiencing this transient risk that takes them. I should say we have some available strategies to deal with the overdose problem. There's no polio vaccine for this thing. And I don't think anybody's moral or political or policy perspective emerges unscathed from an honest appraisal of what's happened. So I'll give a couple of suggestions in the 9 hours that I have available to speak. One is we know less than we should about what's actually happening out there. And we really need some solid epidemiological systems that actually get at the people who are using. One of the problems we have is we have these national household surveys that are almost specifically designed to not get all the people who are going to die. And things like the arrestee drug abuse monitoring system, ADAM, are so important. We have to find ways to reach people that are not the people who carefully fill out the household survey and mail it in as directed because it's a valuable public health thing to do. The survey used to be called, by the way, the National Household Survey of Drug Abuse. Imagine you're talking to people and could you please fill out that was what it was called to the respondents.
Harold, I thought they visit your house. I
Yeah.
thought NSDU, they come to your house, so that makes it even more
Yes.
scarce that they will encounter the people.
So it was just like, I should say, we've all written articles that could be published in the Journal of Selection Bias about the various patterns that show up there. So that's one thing. The crack epidemic, the HIV work, when the drug problem was much more black and brown in its public conception than it is now, that's a welcome change. I must say, I feel a certain sense of sadness at seeing the difference in public reaction, but it's a good thing that people are responding with empathy and compassion. One of the striking things in the ACA debate was that Republicans in the Senate Finance Committee voted unanimously for all of the substance use provisions of ACA. There was never those aspects of ACA and mental health parity. The only prominent Republican that I know of who was against mental health and addiction parity was Tom Price. But really, there was a consensus position among Republicans. This is not an issue where ACA is going to be. We're not going to push on ACA on this one. And one of the striking things is that this is carried over into Medicaid policy across the states in a lot of ways. Medicaid is kind of the ball game on the service side. It's so much more important than the Cures Act or anything else that people are going to talk about. Over the past year, I and my colleagues at the National Drug Abuse Treatment System Survey have been talking to people around the states, policymakers, and we've just been asking how they are using Medicaid to deal with addiction issues. And of course, the opioid crisis being principal in them. And what's amazing, and just given the political map of America, most of the people we talk to are Republican politicians at the state level. And what's striking is ACA Medicaid expansion is kind of the quiet model for successful bipartisan health policy. Nobody on either side actually wants to talk about it, but that's what it actually is on the ground. And people are trying to match Medicaid rules with what we know about evidence-based practice. If you call up someone in a random state, and I'm certainly interested to hear what happens in Arizona, the conversation you have is, well, we're trying to get people into residential treatment where the ASAM criteria say that's what should happen. We're trying to figure out how to get Medicaid to pay for that. And the conversation is about the work. It's not about the politics. And in fact, when we ask people, there's just been an election, does that change anything? The most common answer we hear is what we've been told from our governor is just keep doing the work. Don't pay attention to what's happening in Washington. Just keep doing. And I actually find that very encouraging. Democrats and Republicans around the country are governing, and they're really trying hard to deal with this because they see this map, and they don't want people to die. Drug courts have expanded access to medication-assisted treatment, which is just critical, buprenorphine and methadone. What we see is many states have very antiquated behavioral health systems that they're trying to bring up to speed, and Medicaid is providing the financial oxygen to do that, and that's just critical. I do agree that we have to. Medicaid, of course, reflects everything good and bad about the American health system, and if you're dispensing pills improperly and you give people access to medical care, that is an issue to be dealt with. It's not that Medicaid expansion has killed people, but it has exposed people to all the dangers that come with medical care when it's done wrong. And let me tell you two things from the field in Chicago. So I'm the co-director of the University of Chicago Health Lab. See, if my mom were in the audience, she would have instructed Sally on all the things that were left out of my bio. And what we do is we do randomized trials in Chicago of violence intervention and public health interventions, mostly for people at the interface of poverty, behavioral health, and criminal justice. And so I'm doing a randomized trial right now in the Cook County Jail. And 80% of our drug-involved folks are ACA Medicaid expansion and are insured. 5 years ago, 80% uninsured. That's just, and Sheriff Dart has done an amazing job. Governor Rauner has been very helpful in making that happen. And what we do is we're trying to help borderline homeless people not become one of these statistics. One of the challenges we have is a lot of the people in our jail, they're the urban rabble. So especially the people that have substance use issues, they might be yelling at people, they might be shoplifting at CVS, they might be peeing in the street or fighting, whatever. They go to the jail, and they come out as soon as their paperwork is done. And jail's a pretty depressing place. So you want to get the hell out of there as soon as you can. And so these people, it could be 10:30 at night, and whatever brought you into the jail might have just damaged the social support network that you have where you slept last night, and also may create an issue where what you really want to do is to get some chemical relief from the experience that you just had, the traumatic experience. And so right at this moment of maximum vulnerability, people slip through our fingers because leaving the jail system, and you sort of hope that they show up the next morning at the county hospital for their addiction treatment session. Whether they show up or not, nobody knows. And some of those people die. We know that post-incarceration mortality from overdose is very high. So what we've done is we've set up a series of trailers, our nonprofit partners, where people can get 3 hots and a cot, and they can stay over and get a change of clothes and get taken with a warm handshake to a service provider. And what makes this, by the Pritzkers put up a lot of the money for this. It costs $168 a night or something of that order, which is about what a Hyatt hotel room costs. But Medicaid expansion is what makes that possible, because everything they're going to get when you drive them to any place is a Medicaid thing. And everyone around the country is trying to do stuff like this to deal with these populations. So that's one. I'll say a second thing is that we're involved in reverse stings with the Chicago Police Department, where nonviolent drug users and increasingly drug sellers. One of the misconceptions about police in the United States is that they really want to be arresting nonviolent drug users and locking them up. That's true some places, but it's not true in most places. Police have really gotten the memo that we want to be focusing on violence. We don't, and so they're sending them to us basically and saying, can you partner with treatment providers to find something better if there's someone who hasn't been involved with a gun, isn't a public safety risk. And what's amazing is, especially on the user side, these are older people. Very often they're middle-aged guys getting arrested on the way to work. When the police try to clear out an open-air drug market, they'll arrest the users after they arrest the sellers to kind of shut off that spot. And it very often be like 52-year-old guy who's been using heroin for 35 years. And again, ACA Medicaid expansion is what allows us to do that work. Now, let me just say a couple things about fentanyl. A lot of the people who die from fentanyl don't know that they're ingesting fentanyl. That's one of the challenges. And dealers have figured out you can mix fentanyl with stuff, or you can replace stuff with fentanyl. You have to get the dose right in fentanyl, and that's actually hard to do, and it's easy to screw up. So you have a lot of people on the street who are using fentanyl, and either they don't know what they're using or they don't know how much they're using, and there's a real public safety risk. And I think there's there's several things we can do for that. One thing we can do is thinking about harm reduction policing, which has a sort of liberal edge and a conservative edge. The liberal edge, certainly we don't want to be arresting every drug seller out there. But I think when drug distribution networks are putting fentanyl in their products, that they really need to be a priority for law enforcement. And there needs to be a sense of incentive on the sales side that we will really put extra resources in going after you, not if somebody dies because they used fentanyl, because that's kind of random, but when we arrest you, you're selling heroin, your stuff's going to be tested. And if we find fentanyl in there, you're going to go to the top of the queue for whatever it is that we would otherwise do. Because I do think that we have to deal with this. It's a very hard problem because fentanyl is very cheap, and there's a huge economic incentive to use it. I think in the long run, the drug market's going to move more towards these opioid synthetic products, And as a society, we don't know how to deal with that. It's not going to be heroin coming up from Mexico. It's going to be labs of stuff from wherever. And I'm going to stop here because I think I've gone over. But there's no polio vaccine. But I think if we chip away at this, we can make it better. Thank you.
Thank you so much. Danny, Mr. Seidman?
Thank you. Thank you, Sally. I don't know where. Oh, perfect. So I thought I would start with a quick rundown and just introduce myself by saying I worked for Governor Doug Ducey of Arizona, and it's important to note that he comes from the private sector. His company was Cold Stone Creamery. I saw a couple smiles when I said that, and it's probably the only smiles I'll get from this entire presentation. But I say that because it's important to note he's a metrics-driven governor coming from the private sector, so he's obsessed with metrics, and any of the metrics we look at in this area are not good. And that's a challenge for us. So we have a quick graphic that I put up just to give you a quick snapshot of how we're doing in Arizona. Just a couple of things of note. Drug overdoses take more lives than car crashes in Arizona. So, Harold, we have that going on, similar to Chicago. 4 to 5 new heroin users start by misusing prescription painkillers. 4 over 10 of our adults know someone addicted to painkillers. And, the one that I think is most upsetting is more than 2 Arizonans die each day from an opioid overdose, and that number continues to go up. And because I know Christopher and Nick's work and we read them, in fact, the governor, anytime Nick writes anything, sends things to us on staff to read. I know they're not always the most uplifting, so I thought I would start with one of the few positive slides I have, and that's regarding naloxone or Narcan, which you've heard a little bit about. And this is one of the positive metrics that we do have. We have signed legislation making this available without a prescription, and it's, Sally put up a picture of, I believe it was Paradise Valley, which is a city in Arizona, of a police officer administering naloxone nasally or Narcan to a overdose victim. And because of the amazing ability of this drug to revive or to break through an overdose victim, we've tried to make it as readily available as possible. We're running pilot programs with our DPS state troopers, equipping them with it. And from January to April, we began a program to distribute it to as many at-risk communities as possible. And so far, it's resulted in 492 documented reversals, and that's just this year. So we're proud of that. If you were to not have those 492 reversals, you can imagine what our rates would look like. Now, moving into the less good metrics, as that picture showed, over half the opioid deaths in Arizona are from prescription opioids. You've heard this already, but the U.S. accounts for 5% of the world's population, but consumes more than 80% of the world's prescription opioids. And this next stat I want to focus on for a minute. In 2016, doctors in Arizona prescribed 431 million pills, and that's enough for every man, woman, and child to have about 62 pills. So that's ridiculous. That includes babies, that includes everyone. And that's just Arizona's numbers. I think West Virginia, it was closer to almost 300 pills per person. So there is a problem going on here. And when you look at this, you wonder, how does this happen? Who's to blame? And it's worth talking about. How do we get here? Now, is there a reason why alternative treatments, say there's not a lot of an opioid on the street? That, and there are
In a moment, but Chris Caldwell's article was so rich in terms of talking about what those other dimensions are. And his talk was a great review of how we got here. But I'm hoping he can say a little bit more, your speculations about the cultural, sort of how the cultural landscape became so fertile for this kind of problem. I know it's a hard question and there's not any one answer, but.
Yeah, I think that a lot of it is neglect. I mean, if you look at these parts of the country, the material conditions of life have worsened. I think that a lot of the transition to a global economy has been almost totally negative in those places. you had places that were, generally when you read accounts of small towns going bad in this country, like who wrote that? There was a book about a glass making town in Ohio that came out a couple of months ago. That was yes. Well, there's Dreamland, right, which is about opioids, but the one about Ohio was by Alexander. What was his name? Anyway, you tend to find places that had factories moved out of them or have had declining economic prospects, and they've been reassured that in the new economy there's going to be sort of a new type of thing to do, and that just generally hasn't materialized. So I think there's a lot of neglect.
Yeah, no, that's, one of the points that J.D. Vance made in his book is also, and, I guess this gets into potentially sensitive areas, but something that kind of transcends the addiction problem, although certainly drugs don't help this, but which is a kind of, well, the old word was almost work ethic, but a readiness, not just a preparedness, but a readiness to be a good worker. And, I was talking to folks at International Paper about this because they have a massive workforce and a huge problem with some of their employees having trouble with these medications and drugs. But they even have some factories in these depressed places and can't fill those jobs. So a big part of it is not having enough of those jobs, but for sure. But then there's that strain of when we have these capacities, it's people are not taking those jobs, and there's so much. It seems to me there's so much of that, even when we have some capacity, it's not being taken advantage of. This is the flip side, Harold, of what you were talking about. It's kind of a paradox, I think. At once we don't have enough drug treatment, and if Medicaid expansion is threatened, that will be a big problem. On the other hand, it's the dropout rates when people do go into treatment, assuming they even do go there, because often when people are revived, they don't go with the emergency folks to the hospital. And when they do go to the hospital, they often leave. And when they do go to treatment, the dropout rates are quite large, although it is also true that every day a person spends in treatment is good for them and it's good for society because crimes are not being committed, they're not going to the ER, there's always money saved. But for a lasting recovery, certainly we want engagement and follow through on these programs, which have to be usually at least a minimum of a year of engagement, with or without these medications. And for what it's worth, that's if I had to pick any one thing, and I say this as a treatment provider, I'm a psychiatrist and I work in a methadone clinic, is the engagement dimension of this from the clinical standpoint, is how to keep people in these treatments. And you mentioned drug courts, and those are, I think, an excellent mechanism. People talk about not arresting our way out of this, and I kind of would modify that to say we can't incarcerate our way out of it. For people who do commit crime, sometimes the best thing is to be in the criminal justice system to the extent that it imposes some structure and consequence for folks, and then ideally when they complete the program to erase the record. But anyway, that was my reaction. So that's my contribution, my reaction to what you gentlemen said. Do you want to comment on each other real fast, and then we can go, or just go straight to questions from the audience? Yeah.
I've got one comment I want to make, and this gets back to one of Danny's charts about the incidence of drug abuse or drug use by employment status. If you had an additional line on there for people who are neither working nor looking for work, it would be even higher than for people who are unemployed. In the General Social Survey, when you look at guys, this is in self-reported illegal drug use. It's just a line straight up, depending on your employment status, whether you're employed, unemployed, or neither working nor looking for work. And that kind of makes sense in another sort of way, and this gets to the cultural or maybe the quotidian aspect of it. if you are at home with nothing but time on your hands, and you are a guy, how do you pass the day? The answer, if you look at time use surveys for guys who are not in the labor force, is you don't do civil society. You don't do much in the way of religious or charitable or volunteering. You don't do much in the way of childcare, helping other people in the house. You don't do much in the way of chores. What you do is you watch. And you watch 2,100 hours a year of internet or video or TV or whatever it is, as if it's a full-time job. And this idleness factor, I think, is something that we need to bear in mind. Now, that being said, we have a paradox here that we're looking at, because black guys are more likely to be in this pool of non-working men than Anglo guys proportionately. They're disproportionately likely. But Anglo guys are the ones that we're following on this careening trajectory of deaths. So how come is that? One part of the answer, I think, is if you look at some of the other social survey data, and you look at the survey data about how you feel about the future, optimism versus pessimism. For Latinos and African Americans, the optimism about the future has been going like that. For the Anglos, the optimism has been going like that. I don't know why that is, but I think that probably has more than a passing relationship to some of the trends we've been talking about.
Just one or two reactions. On a very practical level, we didn't talk about PDMPs, but we might have. I think that's a very valuable thing. And I think limiting initial dosing for painkillers is really important. People go to the dentist, have wisdom teeth pulled, and they get a 20-day prescription. That's actually unusual, but it happens. And that should never happen. I mean, there's no question that exposing people to prolonged Vicodin or other dosing is part of the problem. And I think that there's some very practical things we can do that would not just to root out the bad apples. We did a study of dentists, and we looked at and it turned out that we looked at which dentists were interacting with doctor shopping type patients, and we used PDMP data, which was just so valuable to do this. PDMP is prescription drug monitoring programs. So the idea that if I'm writing prescriptions for Vicodin, I consult a database that lets me know who's this patient and are they, what's their issue, and also it allows regulators to keep track of me. And it turns out it's not so much that the bad actor doctors are there. They're there, but it's more that just there's a lot of medical practice and dental practice that needs to be tightened. Now, I mean, on these cultural things and the economic conditions, which I'm certainly not the expert on of others here, I think part of the issue is, I think work ethic is very wrapped up in a sense of hope that people have. We always want other people to demonstrate a very strong work ethic and to go to their crummy jobs and to really put their shoulder to the wheel and do that. And, if you're earning $12 an hour at the International Paper Factory, and it's a dead end for you, and it hurts physically, and you're 52 and there's nothing better, a lot of those people are not going to be incredibly enthusiastic about that. And now maybe they should be. Maybe if they went to synagogue and church more often, they would approach it in a different spiritual mindset. But most of us who are human beings can understand that. And the declining wages and the loss of upward mobility makes it hard for people to show up at work with a smile on their face in the way that we might want them to. And that's just a human reality that these people are facing. I don't know if it has a liberal or conservative interpretation. And it also creates a vulnerability. I think what actually created the problem was the arrival of these medications at the precise moment that this vulnerability was there. And people would not be dying right now if we didn't have all of these pharmaceutical opioids. They might be drinking to excess or whatever, but they wouldn't be dying. So I'll stop there.
Okay. Thank you.
Thank you all for being here. I really appreciate it. The microphone. Oh, thank you. Hi, my name is Dylan. I'm an intern at the Heritage Foundation this summer. This is an issue that's extremely personal to me. And I have a question that a couple of you spoke to a little bit. Sally, you mentioned engagement, and then Danny, you mentioned the importance of prevention rather than treatment. And I guess my question is, so I come from a very affluent family, and my dad died of this problem. And he had a very engaged family and a very welcoming and helpful community that was surrounding him with support and love. And he went into treatment, and there were multiple times that happened, but it didn't do any good. And so I guess my question is, if that can happen, and that's an issue that is a prevalent issue. It's not just my dad. It's happened many times. And I guess if that happens in an upper middle class family in a great community with great support systems, why do you think that mandated treatment, because it's a fact and a well-known thing in the community of addiction that if the person doesn't want help, it doesn't matter how many people make them get help, they're not going to get better. So why do you think that mandated treatment, or that somebody holding their hand when they come out of jail to take them to these treatment facilities, if my dad didn't care when I held his hand taking him into treatment, why do you think that a stranger is going to do any good for someone with no hope and no job?
That's Mike. Well, it's very interesting in my clinical life. I always felt people like your dad were the hardest. People like the movie stars are the hardest. People who appear to have everything but must have, and we're not going to get into anything specific here, but generically must have some inner pain. They're the hardest, because we could educate people, and we could do voc rehab. We could have more methadone clinics. We could have, for people, I always felt like for people who appear to have nothing, whose kids were taken away, we can help them learn how to get them back, and how to be more responsible moms, and how to do relapse prevention so that they can handle their craving when it happens, and teach them how to walk home. I'm serious. There's all kinds of specific little strategies you use with people. Don't walk home on the same route where your dealer is. Don't get your paycheck. Get it direct deposited. All these kind of little strategies you put between yourself and the kinds of temptations that there are. Well, your dad knew how to do all that. He's a tough one. That's very tough. Now, it is true, though, that, what you said is something a lot of people believe, but we sort of know from the criminal justice system, and even from civil commitment, which actually is being considered more and more for addiction, where it's typically been considered for people with psychoses and who are dangerous to themselves or others and are gravely disabled, is that actually people who are coerced into these programs typically, now maybe some people will just never do it, but typically actually come around. It's when they can just walk away, which they often do, because a lot of these folks are impulsive to begin with, and if they're feeling the urge to use, that often takes over. But when you can keep people standing still, that's frequently the experience at Phoenix House, other places that are long-term residential, and they're insulated from their old, the cues, the conditioned cues. They often internalize the values of that system after a while, but not everyone does. It's true.
Yeah, can I just say two things about that? I'm so sorry to hear your story. I think one of the big lessons from your story is these drugs are just really hard. And people have different vulnerabilities to them. And some of it has to do with the way your brain is wired, and some of us, we get a shot of oxycodone and our dopamine receptors are like, wow, that's the thing. And some people, it's an unpleasant experience or a medium experience, and your dad may have been one of the people that had a vulnerability to that. A very large percentage of the wounded warrior group in the military, and a very large percentage of cancer patients develop substance use disorders on these painkillers. They are really, really hard, and I think I would never want to say that we've got a brilliant solution to that, and he's certainly not the only one, and I think a sense of humility is important. I do think the things that we suggested help, and we have to do randomized trials to see which is helping, which is not perfect, but which is helping. And that's the basis that we operate on. But I assure you that many, many people who are really rock solid in so many aspects develop a really serious problem with these medications.
I would just add one thing too. Thanks for sharing your story. I think not everyone, but a lot of people have similar stories from all backgrounds, and that's the unique thing of this crisis. One of the things that we talk about doing during our health crisis is requiring a psychological evaluation before a first shot of dopamine would be given, before Oxycontin would be given. That way, maybe you catch the person who would that would be, this is my thing, this is what's going to make me go wild, and you don't ever get down that path to begin with. But there is no panacea. I don't believe that, either. But I think, it took a lot of courage to share that. So I appreciate you doing that. And it's important for everyone to hear that this isn't just, West Virginia, low-income people without jobs.
Tim? And we'll get to everyone.
Thank you. Tim Carney, I'm a visiting fellow here at AEI, commentary editor at the Washington Examiner. And I wanted to try to nail down a little more what we mean when we talk about culture, right? Because usually at AEI, it's all these people, they put up numbers, it's about jobs, and then culture is sort of the basket we put things that we don't want to nail down. But I think you guys hinted at a mechanism a little bit, and there was the article in the New Yorker, I think, Margaret Talbot, 2 days ago, in which she talked about this West Virginia town, and one of the local officials said it's a social vacancy is what he identified the root cause of the opioid crisis there. And Chris, you talked about 1970s heroin, collapse of the social order. And Nick, you talk about idleness, and a lot of times when conservatives talk about idleness, it sounds like we're attacking these people. Maybe you are, but also idleness means nobody's giving you something to do. I know in our life, we constantly have people giving us stuff to do. So if you don't have these institutions of civil society around you, that means not only do you not have a safety net, it also means you don't have kind of a sense of purpose. And can that sort of the dissolution of institutions of civil society, is that one step further down the line get us closer to understanding what could be the mechanism of the cultural roots of the rising opioid crisis?
I think these are problems in any weak society, and then I think that our society's been getting weaker. But it's the drugs that enter it into the mix, and I'm just thinking aloud here. For a long time we've had very restrictive attitudes about marijuana, much more restrictive than we have about alcohol. Even though alcohol is a much more addictive drug, it's a much more dangerous drug. But the difference is that it's our drug. And it's the drug in our culture, and we have all sorts of rules and rituals for regulating it, which we have not had with marijuana. I think the same is true of this incredibly dangerous complex of drugs called opioids. And so I think that the absence of things to do, the absence of meaning in society, the every man for himself attitude, which is sometimes taken as a virtue among Washingtonians who call themselves conservative. I think that's poisonous in any society for a lot of reasons. But it's poisonous because it just leaves people vulnerable to all kinds of bad things. Poverty, losing your family, crime. We're talking about one of those bad things today. So I think that it creates the ground for all sorts of things. But what we're really talking about here now, I think, is limiting the oversupply of these drugs, and also sort of like dealing with ways to get people out of this problem when they do have this. When they do have this problem. And I think that the answer to the question that the young lady asked, I think, is that once these drugs close their grip on a community, you're going to lose a lot of people. There's not much you can do. And I think that what the most successful programs have tried to do is throw everything but the kitchen sink at them. They visit people in emergency rooms. They use methadone. They use some of these new opiate mimicking things like buprenorphine. They have 12-step programs. They have employment programs. They are fighting it on every single front, and I think that's in order to rescue maybe only a minority of the people who have these addictions. So it's not a, it's a drug problem, really.
Can I try to take a crack at that also? Yeah. I mean, so idleness. Idleness is a very stigmatizing word. And the reason that idleness is a very stigmatizing word goes back in a couple of different religious traditions, a couple of thousand years, because a couple of different major religious traditions regarded idleness or sloth as sinful, and not only as corrosive of one's own soul, but scandalous in the sense of corroding the possibility for others. But that was then, and this is now. So free time can be idleness. Free time also can be leisure as the basis of culture. All societies require free time as the basis for culture. The distinction as to how time is used is critical in this regard here, and that may be getting towards the mechanism that you're describing. I mean, I was looking in particular at what happened with the Anglos, and the canonical book on this obviously is Charles Murray. And what Charles has described from 1960 to the present, with the bottom dropping out for less educated Anglos with regard to family, work, and religion, is hardly coincidental to where we are now. I can't put together the mechanisms, but that's a big background. And where does that leave us with idleness and everything like that? Well, we can kind of update Marx now. Opioids are the opium of the masses, right?
I would just say one point about this. I don't know how to address the culture thing, but many, many people who have very serious addictions, when they're in medication-assisted treatment, at any given moment, there's an awful lot of relapse and co-occurring drug use and so on. There's a lot of people, probably some people in this room, who've had an addiction and have been able to be functional and to lead valuable lives that are very meaningful to them and the people around them. And we can help people do that. And it is, and we need to have a sense of optimism that even if someone is on medication-assisted treatment for a long time, they can be much more functional and successful. I work with a lot of those people, and so do you, and you don't know a lot of the people.
Yeah, right. People come to the methadone clinic 6:30 in the morning, take it, go to work. Okay, we've got to get at least one more question in here. This lady? Make it a policy question.
Hi, I'm an analyst with McKinsey, focus on healthcare analytics, and I agree with a lot of you guys how data is so powerful and helpful for solving or understanding this issue. So I have two separate questions. One is about interventions. When you guys do these randomized control trials and implement Vivitrol, have you also looked at how to carry out community-based interventions to not only provide these criminals or people with service or with naloxone, but also how their effect to the community once they return will be, as in whether they will return back to a drug dealer, how they would influence their families, and so that would be my first question.
Do you want to, and let's just, Danny, answer this, and then we'll take another question.
Sure. In regards to the Vivitrol pilot, yes, it actually requires them to go to come back and meet with a counselor, and I think it requires group counseling as well. So we are recording that data. I don't think Vivitrol in isolation would work, and I don't think that's a best practice. I think what you're saying is right. They do need integration. They do need to have a better purpose. So no, it's not. We're not looking at that in isolation. In any one of those pilot programs that we've mentioned, I think the best example to answer your question would be the emergency room. That when we have administered naloxone to someone and we have them we have them inform them about treatment facilities, and if they do take them up on that, our access is following up with them now, and we are tracking that data now. And I hope in a year to have better data. Actually, now that we're in a state of emergency, I can get that information on the ready. So one of the good things about being in a state of emergency, as sad as that is that we're there, I should be able to know more about that. But yes, we are tracking that because the data is important, and we want to know where they're at and how they're doing.
Awesome. And just one quick question. Recently, I saw a study about providing a safe environment for opioid users to prevent overdose, and it has been implemented in many cities in Canada. And recently, Johns Hopkins Bloomberg School of Public Health also said that it's effective. And so, what is your opinion on such kind of intervention?
The question is about safer injecting rooms, where people can go, street users can go and inject in a supervised environment in one way or another. I mean, I'm glad that the Canadian folks are doing that, and it's an interesting harm reduction intervention. And there's some evidence that it is valuable for people. I think in a U.S. context, I probably would say, I would never oppose that, but I would say, boy, I've got a bunch of things on the list that I would want to do first that are much more consonant with just the norms of American drug policy. There is, I think that in terms of overdose and HIV and hepatitis risk, the safer injecting rooms definitely have value. So I certainly would not criticize them. And in Western Europe, there are a number of models like that that have been useful.
So Seattle's supposed to open one any minute now.
Yeah, I would want to
get to prospectively study them, because they rarely are prospectively studied, and they're rarely studied by groups independent of the people who run those clinics. So something to observe, but I think your point is incredibly good about the norms of and priorities. So I think we have time for one more. That gentleman in the back. That's.
How are you doing? I'm an intern this summer with the Urban Institute, and my question has nothing to do with any views or anything, but to speak a little more in detail with harm reduction, I was curious. I noticed that you all spoke to the use and chipping away at the issue. I was curious if you all can speak a little bit to the needle exchange program and maybe how that may work in society here.
Actually,
the
that's
coach
pretty
we
much
had.
the same. Needle exchange is already quite accepted, and that's exactly what Harold was talking about in terms of reducing HIV. And
syringe exchange is an essential program that
Yeah.
should be fully supported aggressively.
Okay. So I think
my
we have time
perspective.
for another one. The lady next to him.
Hi there,
Thank
I'm Dr. Kurlish, and I'm a provider at George Washington University in the Emergency Medicine Department, and I'm a medical advisor for the National Safety Council with respect to the opioid epidemic. So I appreciate your focus on prevention. I do state-level CME myself. I'm curious, though, if we could talk a little bit more about opioid use disorder treatment. As Dr. Settle can explain, not all forms of treatment are created equal, and medication-assisted therapy is really the way to go. I know that we've talked a lot about what happens with emergency-based referrals, and I will say that our screening, brief intervention, referral success is only as broad as the community networks that we have available to actually shovel patients towards. So my question is, what do you think is the most economically feasible way to expand access to medication-assisted therapy at the state level?
I'll go first, and I'll say I think I referenced that if we, let's say healthcare stays exactly the same, and I'm not going to get into the politics of that. If they just give us more flexibility with how we spend those dollars, I think that we can address the crisis of the day, and right now this is the crisis of the day, and I think that our access would be able to spend money on programs like that and recognize that as a best practice. And that's what we'd like to do. We'd like the ability to do that with these dollars, but we're restricted a lot of times with how we spend those Medicaid dollars.
Yeah, I can just tell you, I'm not a doctor, but I can just tell you what I've heard going around in New England, talking to people, particularly in rural areas. In Maine, and I don't know if this is right or wrong, they are trying to save. They're trying to make their savings by doing outpatient rather than inpatient programs. That they think that if with medication-assisted treatment, which is the programs that I was talking to, just having a daily visit is just as effective as a multi-week stay. Although, as I say, I don't have a medical opinion on that.
So just a quick comment there. I think there are a couple things we can do with medication-assisted treatment that would make it work better. I mean, obviously, the first thing is don't screw up Medicaid expansion, which is going to pay for a lot of this. But I think that the marketplaces It's interesting, all these governors that we talk to who are really sophisticated about Medicaid are totally disengaged from the marketplaces, and that's where some of the low-income people are and where the addiction services are often very spotty. I do think that also finding ways to integrate primary health care with addiction treatment is so critical. You know, if you developed an addiction issue, most of us in this room, and I said, you know, there's a drug treatment center that's in Washington, D.C. at such and such a place. There would be 5 major psychic barriers that would really stop you from walking in that place. Most of us, if we're going to get any help at all for a mental health or addiction problem, it's going to come from our doctor and the person that our doctor connects us to. So making that linkage, and SBIRT that you mentioned is one way to do it. Mixed record in the evaluations, but clearly it's a model that should be pushed on. We have to make it something that is part of the continuum of medical care because so many Americans are experiencing it.
Thank you so much. Hey, thank you everyone. Those were really excellent talks, and thanks everyone for your interest in the issue. Yes, we don't have our next lecture planned, but you'll all get notice of that. Thank you again.
I really enjoyed what you had to say when you talked about it.
Oh.